This is something that not everyone needs, fortunately, but something that I think is important to know about, especially if you have myelofibrosis and it's something that your doctor's mentioning, because it is a really scary thing and there's a lot of information out there. And so just to try to kind of put it in perspective, and I come at this as both a transplant physician, which is where I started my career, as well as a myeloproliferative disease physician, which kind of happened mid-career for me. So first of all, what is a bone marrow transplant? So it involves getting chemotherapy, and the chemotherapy, depending on age and a number of other clinical factors, can be high dose or sort of an intermediate dose. It gives you a new blood system that'll actually work better because your blood system has a problem with it. And also these new stem cells, this new bone marrow you get provides a new immune system that can actually go after and attack any last bits of cells that are left behind, because myeloproliferative disease cells are super strong and very resilient. So you really want to make sure you have another thing additional to chemotherapy to help knock them down. So you'll hear two different types of transplants, and this is important because everyone's like, oh, I know somebody who got a transplant and they were better in 6 weeks or better in 6 months. And so there's two different types. There's autologous stem cell transplant, which is where you get your own cells, and we use it for diseases like multiple myeloma and lymphoma. And then there's allogeneic stem cell transplant, which is where you get cells from somebody else. We don't want you to get your own cells back, so we always do the allogeneic transplant. So the other thing that's confusing is sometimes will say peripheral blood stem cell transplant, hematopoietic stem cell transplant, bone marrow transplant. These are all the same things. Ultimately, what we want to do is we want to get the bone marrow stem cells or hematopoietic stem cells, which live in our bone marrow. We collect them, and there's two ways of collecting them. The first way is to actually bring somebody to the operating room and stick them in the backside a bunch of times, do basically like 50 bone marrows per side, and literally pull the marrow out. The other way to do it is to give somebody a shot in the arm for 5 days, which revs up the bone marrow and kicks those stem cells from the bone marrow to the peripheral blood, and then we can collect them in that fashion. And so these are the two ways that we collect it, which is where we got bone marrow transplant and peripheral blood stem cell transplant. And this is how you collect, the donor gets collected with leukapheresis. So how does the transplant work? The donor gets chemotherapy, sometimes inpatient, sometimes outpatient. And at the same time, either simultaneously or before that, donor gets collected with their stem cells. After the chemotherapy, literally the chemotherapies may be over 5-6 days, sometimes 4 days, depending on the regimen. There's a day of rest, and then you get the stem cells, and they go in just like a blood transfusion. So when they go in, your counts probably haven't even dropped, and you just finished the chemotherapy. And then after the stem cells go in, then it's a situation where you get more chemotherapy that helps prevent some of the complications. So when should you see a transplant specialist? So it's really good to see them before you need them. See them early in the disease. If you're somebody who's young and you have myelofibrosis, chances are at some point in your life you're going to need a transplant. And honestly, even though I have kind of mixed feelings about it, because on one hand, when you come and see me, I'm going to scare you and put kind of a black cloud over your head. On the other hand, if that's eventually coming, you kind of want to know about it, and you want to know the things you need to have in control in your life in terms of having caregiver support. You know, put yourself in a situation where financially you'll feel comfortable, and lodging. And then it's important to understand the process of transplant. If you have to kind of absorb it all at once, it's really overwhelming. And this way, we always give people this book, and I tell them, I said, read the book, and the minute you get overwhelmed, just close the book and put it away for a while and then take it out again. And so this gives you time to process all of the information. So who should you see? It is important to see somebody who has a knowledge of transplant and myelofibrosis. I think there are definitely unique aspects to myelofibrosis that require attention from somebody who understands the disease, and there are a number of us across the country. You don't even necessarily need to get your transplant where they are, but it's always good to kind of talk to somebody about the timing and the different factors that we include when we're considering transplant. So what to expect during this consultation? Bring somebody with you. Do not go by yourself. It's scary, it's overwhelming, and there's a lot of stuff. And record it if you can. Because everyone, even if you have two people, you're going to be like, I thought she said that. No, I thought she said that. Be prepared to be scared. If I don't scare you, I haven't done my job, because this is a scary process. If you can, record the consultation. And if you have any doubts, get another opinion. I mean, no doctor should ever be upset if somebody wants to go get another opinion. I encourage it. I'll give them names of people to go see. because it's really important that if you're going to undertake something like this, that you feel very comfortable with what you're doing. So when should you get a transplant? Well, this is something that, you can get lots of arguments even amongst transplanters who know about MF. It's generally reserved for people with intermediate or high-risk disease. There's a lot of nuances in terms of who the donor is and what the comorbidities, like what other medical problems a person has. So it's not something that I can just give you a flat-out answer like, this is it, this is when you're going to need a transplant. Because honestly, the way I look at it, there's a window of time where people can get a transplant, and you're, depending on where you are in that window, or if you're in that window at all, really helps sort of us determine. And just importantly, if you're not sick enough for a transplant now and the doctor says you don't need one now, it doesn't mean you'll never need one, for better or for worse. Like sometimes they'll be like, well, the doctor said, no, I don't need a transplant. It's like, well, no, you don't need one now. You will eventually potentially need one. So how do we define risk? So there's lots of ways that we define risk. They all have caveats. I think the important thing to remember about any of these risk systems, because sometimes you can find the calculators online, I think that elements that we consider as risk elements are extremely important. And they definitely, are things that I look at every day in clinical practice. The survival times, however, I really encourage you not to look at. Because first of all, that's the time in the survival where half the people are alive and half the people aren't. So it's not like a clock is ticking. And the second thing is that some of these, like the DIPSS and DIPSS Plus, were actually created before ruxolitinib was even available clinically. And that's huge, because that really has changed outcomes in myelofibrosis. So we have to really be cautious with looking at survival curves. So if there's anything you're going to remember, these are really important features, but don't look at the survival curves. So when we talk about risk, anemia is generally considered a hemoglobin less than 10 or 11 if you have secondary myelofibrosis. Thrombocytopenia, platelet count less than 100. A white blood cell count that's elevated, we generally consider 25. So if you're 11.2, which is generally elevated on most scales, that doesn't necessarily mean you have that risk. Blasts are immature white blood cells in the peripheral blood. So when we talk about percentage blasts, that's what we're talking about. These are also, this is also the name of the cells that we call leukemia cells. So if somebody has greater than 20% of them, it's considered leukemia, and we start referring to them as leukemia cells versus blasts. But if they're less than 20%, it's not leukemia. And especially if there's 1 or 2 or 3%, I see that really frequently in patients who have myelofibrosis, so it does not mean you have leukemia. And in fact, I've had people who I followed for years who have that percentage of blasts. Now, abnormal karyotype. Karyotype is something, and I'll kind of go over it in the next couple of slides. And then constitutional symptom, karyotype's a genetic thing, and constitutional symptoms, which is fatigue, weight loss, decreased appetite, night sweats. Now, if somebody just has isolated fatigue, I don't always consider that as one of those risk factors. Obviously, it has a great impact on quality of life, but the ones that I think really probably are contributing to a lot of this are things like night sweats and weight loss, and some of the things that indicate the body is really kind of in overdrive. So this tool was created a while back, and I'm not sure completely the accuracy of it, and you have to be cautious with using it, but it was a tool that was trying to generate an idea of the spectrum of timeframes for transplant. And generally speaking, I think intermediate 2 or higher risk is what sort of is a kind of a baseline. But there are people who have intermediate 1 risk and potentially even low risk, depending on mutations, that may need a transplant. So what I talk about is, when you need to think about transplant, again, is early on in the disease. But then when we do transplant, it's usually around intermediate 2, but we'll kind of talk a little bit further. So what other things contribute to risk? There's a driver mutation. Cytogenetics and molecular mutation. So driver mutation is what causes your disease. There's the JAK2, calreticulin, and MPL mutations. There's also some people who have no mutations, and that's actually worse, believe it or not. It sounds kind of counterintuitive. Calreticulin type 1 is actually good and generally conveys a less aggressive disease. And as I said, no mutations is unfavorable. Cytogenetics, so, they do, remember when women were pregnant and they were like older than 35, they did this amniocentesis where they basically pulled cells out, and then they made them into this thing where they put X's, have a bunch of X's and in case of men, Y's. And basically, they laid it out, and this is kind of what a karyotype looks like. These are all your genes. You have you get 23 genes from each parent, so you have 46 genes. And what we're talking about with this is, let's say that one of them is missing, or half of one is missing, or sometimes they switch places. So like part of one will go to 3, and part of 3 goes to 1. These are rearranged. These are the changes that we look at. Now, these are not changes that you've had since birth. These are changes that occur with the disease. Then there's other molecular mutations. Now, these aren't things that we can tell just by looking at the X's and Y's. Now, for each of those X, there's tons and tons of genes and chromosomes. Tons of genes on each of those X's. These are the genes that are on the X, and this is where something has changed. So what the end result is, you make a protein that's different than the one that was initially made. So for example, with the JAK2 mutation, when you have a mutation in JAK2, it forms the protein different so that it does the wrong thing. It makes the cells grow too much. In this case, it makes something else in the cell grow too much, and we generally know that certain mutations are associated with worse prognoses. And so the ones in primary myelofibrosis that we look at are these 6 mutations. Now, panels will have anywhere from 42 to 402 gene mutations, sometimes even more, depending on where you're getting it done and whether it's a clinical one or a research one. But these are important, and it's important to understand, if you have myelofibrosis, what your mutations are, because they definitely help us in thinking about transplant, and you really can't make a good decision without them. And so basically what that does is that puts our just right to a little bit earlier when you have some of these high-risk features. So that's why when you talk to your doctor, it does get very confusing. And I think even a lot of transplanters, with transplant, we pretty much, when they come to see us, most of the people, they come and we say, yeah, you need a transplant because you have a disease that needs transplanting. But understanding the timing of all of this is really important. Other things to consider: symptom burden. This one's tricky because if somebody has intractable fatigue, but everything else looks okay, it's a very hard justification to do a transplant. Have they been on ruxolitinib or not? We know people who progress through ruxolitinib, that generally conveys a higher risk disease. People have had a good response to ruxolitinib. We want to try to capture people during that good response. Transfusion dependence. That's an important one. If somebody's transfusion dependent, even if none of these other risk things are there, that actually is a high risk thing, because that means somebody's getting blood and, with all the other things that can go along with blood transfusion. And understanding what gives you those points. So questions: you feel so good on Jakafi. Should you really proceed, or ruxolitinib, should I really proceed with transplant? The newer agents in clinical trials, will they make this different? Will they fix the disease so that you don't need a transplant? And should you do a clinical trial first, then a transplant? Now, I can't actually give you answers to any of these questions. I can say that as of today, I don't think any of the drugs that we have in clinical trial, although I think they're incredible and will make a very favorable difference, especially once we figure out how to analyze them appropriately. These drugs are great. None of them are going to fix the disease, and this is one fix to the disease. So what happens with the transplant? So things you need to know ahead of time. Number one, you'll be seen daily for about a month, because that's the time frame that you get the chemotherapy. Your cell counts drop down to 0. You need blood transfusions, platelet transfusions, infection risk, and then your blood counts eventually recover back to close to a normal level. But during that time, you're really going to be seen very, very frequently. Sometimes it's inpatient, sometimes it's outpatient, depending on the transplant program. You will need to live near the transplant center for at least 100 days. This is usually a non-negotiable, and that's because things can happen, and we want to make sure that we're there to be able to address them. So if somebody lives, like in Arizona, we have a lot of areas that are pretty far from our transplant center. If somebody lives in, for example, Lake Havasu, which is close to Las Vegas, and they get sick, the hospital that they're going to go to is not going to understand their disease and sort of the acuity of what's happening. So it is very important to stay near the transplant center. You need a full-time caregiver, 24/7. This person can go to the grocery store for an hour, but that's about it. And it's not that you're going to need somebody to help you to the bathroom necessarily or things like that, but you do need somebody who's going to be there, because if you get sick, we need to know. And sometimes when you get sick, you don't quite realize it. It's also a little bit of a conscience on your shoulder. You have a fever, you'll be like, oh, I have a fever. I don't feel like going in. I'm so tired of the hospital and going there. But that person will also help say, hey, you know what? We got to go. You're going to have a lot of restrictions, diet restrictions, social restrictions. We don't want you to go into any crowds, don't want you to go to church. Thankfully there's online church these days. We don't want you to do a lot of things because I don't want people exposed to infections, because there's a great aversion to wearing masks in this country. So people are sick and they go out and they don't wear a mask and they cough, and then you can get sick. And then you may need to be off of work for up to a year, sometimes more depending on what complications you have. So donors, if you do not have a sibling, that's okay, because actually more common than not, we've used a lot of unrelated donors because age is a really important factor into the donor. There's over 40 million potential bone marrow donors who are on the registry around the world, and you have access to all of them. Be the Match is generally the agency we go through. This has 11 million donors, but then they have access to and can reach out to the DKMS, which is a German registry, and the World Marrow Donor Association, which is also an international association. So finding a donor, especially if you're Caucasian, is probably 70 to 80% chance. It does change depending on the ethnicity. African American ancestry, it's probably about 60%. If you get to like Pacific Asian, it can drop to 40%. So it does depend on ancestry. Now that being said, when we talk about HLA, it's really conserved. So there may be a relative that is way, way, way back before any of this stuff, that before anyone knew, that happened to put a HLA marker in there that's uncommon. When we talk about matches, you're going to hear 6 out of 6, 8 out of 8, 10 out of 10, 12 out of 12 sometimes. So what does that mean? So there's 6 basic markers that we look at: HLA A, B, C, and then there's DR, DQ, and DP. And so when we say 12, we're including all of them. Now, DP, frankly, isn't that important. In fact, sometimes a mismatch can be better than a match. And that's where we get the 10 out of 10, which is where we exclude the DP. Now, DQ is also not one that actually has that much implication on outcome. And so a lot of times we look at 8 out of 8. So we look at these 8 markers and try to match them. Because again, if you don't match on DP, that actually may be beneficial. But if you don't match on DQ, honestly, I don't really pay much attention to it. It's kind of left in there for posterity's sake. So should your relative be your donor? Each sibling has a 25% chance of being a full match. That's it, 25%. 50% they'll be a half match. Now, if you're an older adult and you have adult children, your kids are also a half match. And I'm certainly going to go with that child versus going with somebody who's older, because we know age is important. And then if you have a parent or a child, depending on your age, they will always be half matched, because half of your DNA comes from them, unless of course there's donor egg or donor sperm or some other reason. And then selection of a donor is something that's been a moving target. I used to say, I want you 10 out of 10, and that's who I'm going to transplant. However, we now will see that mismatched donors, there's ways we can overcome that, and even half-matched donors. And even though there may be a slight difference in terms of outcomes in the first few months, once you make it past that first few months, it kind of is equal. So we definitely can use different types of donors, which has made it a lot better, because most people then will have a donor. The only donor that we don't use for myelofibrosis, or don't recommend using, is a cord blood. And the cord blood is the blood stem cells that you get out of a placenta after a baby is born. And there is a cord blood, people donate their cord blood, there's a cord blood registry. Those cells are probably not as good in myelofibrosis. But everything else is game. So the vast majority of people now have donors, which is huge, and a change that's occurred during my career. I used to say we won't really do a haplo unless it's on a clinical protocol, and now it's standard of care. So what to do with a large spleen? There is not one answer. As you'll see, unfortunately, a lot of what I say today is that there's not one answer, one size fits all, and these are all discussions you have to have with your physician, because they're very nuanced. But that being said, we generally do like to shrink the spleen some. I usually prefer to do it with JAK inhibitors. I very seldom take it out, but people can get splenectomy. There's doctors who are very good at doing that. Splenic irradiation can happen, but usually by the time your spleen shrinks after radiation, it's a little bit further out. So the timing of that, the dosing, everything else is not completely clear. So again, this is an individualized decision, but we prefer to get people when they've had a very good response to a JAK inhibitor and their spleen is shrunk. Now, that being said, if you get chemotherapy before your transplant, that can also shrink the spleen as well, but we want to try to have people come in the best situation. Conditioning regimens, there's myeloablative, reduced intensity, and non-myeloablative. Myeloablative is pretty much I'm wiping everything out, and if you don't get stem cells, it's not going to come back. Reduced intensity means I'm wiping everything out, may come back after a while in the absence of getting additional stem cells. And non-myeloablative means your blood will, you'll basically recover without difficulty, even if you don't get stem cells, and we're relying on the immune effect. GVHD prevention. So graft versus host disease is the biggest fear. So when I give you that stem cell, I do it so that you have a new immune system to attack the bad cells. Well, sometimes it can't differentiate the bad and the good cells. And even though we've been trying for 20 years, we haven't figured out how to separate those two effects. So we often give chemotherapy after the stem cells. There's two different ones that we use. One is methotrexate, which is what we've used historically. And then the other one could be cyclophosphamide, which is another chemotherapy. So you might say, why are you giving me chemotherapy after you give me beautiful new stem cells? Aren't you going to damage them? Well, the good news is with methotrexate low dose, it doesn't really affect the stem cells. And with cyclophosphamide, even though we give you a high dose of chemotherapy, those stem cells actually can kick the cyclophosphamide right back out. So it's a really nice little glitch in the blood system that makes cyclophosphamide work well in this setting. And then there can be immunosuppression medication that comes in pills that you'll take for a while after transplant, sometimes 3 months, sometimes 6 months. And then if you have graft versus host disease in the long term, it can actually be several years that people can be on these. And then there's other interventions that people use depending on the transplant center. Now, again, this is also not a one-size-fits-all. If you come to see me, I will use one thing. If you go to see the doctors at Sloan Kettering, they might use something different. And so depending on where you go will really depend on what they use. But one thing that is encouraging, post-transplant cyclophosphamide. Now, this study, unfortunately, I usually try not to include survival curves, but I think this one, it's important enough to demonstrate. If you look at survival curves, this basically is how long somebody lives and then basically what's the percentage of chance that they'll get this over time. And so what they did was they used post-transplant cyclophosphamide, which is basically using that high-dose chemotherapy afterwards versus our standard, which was methotrexate. And they found that we've really reduced the risk of graft versus host disease. So this has been a really, really favorable thing in transplant that we've done. I will say that in the setting of myelofibrosis, it's not completely clear that this is going to be the right answer, but it is something that just brings a little bit of hope. And I can say as a transplanter seeing these patients, it has made a difference. I still am not 100% sure it's going to be the right answer for myelofibrosis, but I have been using it. So graft versus host disease, again, this is something that typically involves initially the skin, the liver, and the intestines. Long term, it can involve almost any organ system in your body. The acute graft versus host disease, trust me, you are going to know it's there. A lot of people say, oh my God, how will I know? What is it? You'll know it's there, trust me. And you're being seen all the time. You're being seen twice a week. That's why we don't let you leave, is so we can watch you for this stuff. Chronic GVHD can be a little bit more insidious. It can be dry eyes. It can be dry mouth. Sometimes you can get skin thickening, joint tightness. So these are things that are really important when you notice something to talk to your transplant doctor, because a lot of times I've had people get diagnosed with a rheumatologic disease and they actually have chronic graft versus host disease, which should be treated differently. Infections. So there's a lot of different infections that people can get. And these are related to the different things that we do to the immune system. And plus, remember, I'm giving somebody a brand new immune system. It has to set up housekeeping in your body, start to work, and then relearn everything you've learned over your time on Earth. I mean, all of us have had so many colds and flus and stuff like that. We have all this immunity. We're waiting and ready to be able to fight stuff off. So, for those of you who've had kids, you send them to preschool and they get sick every week and they come home and they make you sick. But they get sick every week because they haven't built up that memory of immunity. So it takes a while to build up that memory again, which is why I say you don't go to crowds, you don't go to places where you're exposed to a lot of people, because if you get one of these, it's a lot worse for somebody who gets this versus somebody who has an intact immune system. And then relapse. This is one of those scary things that we talk about. And relapse is a little bit different in myeloproliferative diseases than it is in other diseases that we transplant. First of all, there could be molecular relapse. So somebody has no evidence of disease, but all of a sudden we see some of their own cells coming back. And we can detect that by something called chimerism, which is able to differentiate donor cells from the person's own cells. Sort of like the way, you know, when you watch like CSI or something, they have that thing they hold up to the light and it has all those little lines. That's basically how we do chimerism, is we look for the special lines for each person. And so sometimes when we see decreased chimerism, there's approaches that you can take, like tapering off immunosuppression, or sometimes even giving cells from a donor. But these are, you know, this is something that your doctor will be following. They'll be looking for a JAK2 mutation or MPL mutation, whichever. And they'll also be looking at chimerism. Now, another, not one size fits all, and it is somewhat of a nuanced approach. There are things that can be done. And overt relapse is when I consider somebody has evidence of the disease. So they start to have a high white blood cell count, or they start to have more worsening anemia. Most people have trouble recovering their counts after transplant with myelofibrosis, but worsening anemia or other signs that make me think the disease has come back. But again, this is something that is somewhat nuanced, and when we talk about what to do about this relapse, again, it's very individualized decision and something to discuss with your transplant physician. So what are some women-specific issues? This is a women in MPN meeting, and so to talk about that, fertility preservation. This is a really important thing if you're young, and we do unfortunately get some young people for transplant. So making sure that if this is something that is on your list, fertility preservation is important. Early menopause. After having a transplant, especially if you're premenopausal, a lot of times that can make people go into early menopause, or at very least, if they do, if the cycles return, go into early menopause. Osteoporosis, which women have a higher risk for anyway. And then finally, post-transplant sexual difficulties. It's a really big problem after transplant. So fertility preservation, you really need to talk to a fertility specialist. There's a lot of things like whether you have a partner who you want to be the father to your children eventually, and in which case you would collect eggs and make embryos. But there's a number of different ways that fertility can be preserved, and I think we're getting better at it over time. So that even if somebody doesn't have a partner and says, well, I don't know who I want to father my children, you can actually even save the eggs by themselves, and they've gotten a lot better at being able to utilize those to ultimately have a child. Early menopause, again, very important to monitor. For people who are younger, I often will encourage hormone replacement, at least until the time where menopause would occur. As we all know, hormone replacement is also a very individualized decision, and unfortunately one that we're not very good at in myeloproliferative neoplasms yet. But this is something that is important. Osteoporosis, there's a lot of things that contribute to it. First of all, women are at higher risk for it because of estrogen loss. But the chemotherapy, medicines that help prevent and treat graft versus host disease, et cetera, they all increase somebody's risk for osteoporosis. So I actually see it in a lot of men post-transplant too. So these are things to make sure that you have your bone density monitored regularly, and even start earlier than one would start had they never had a transplant, because I think normally they start at 65, but if you've had a transplant, you have to start after the transplant pretty much. And then sexual issues after BMT. Over half the women have sexual issues post-transplant, and there can be vaginal dryness because of postmenopause. Graft versus host disease can actually impact the vaginal area and can cause thickening of the skin and sometimes even adhesions. Hormone imbalances due to glucocorticoids, anxiety and depression, which is incredibly common after transplant, and body changes that result in altered body image. I mean, a lot of times people look very different after their transplant than they did before. And this is something that can be, I think, hard to overcome. So talk to your provider, and there's a lot of physicians out there, they're often primary care physicians who specialize in women's health and in hormone replacement, and like when do you use hormones and when do you use testosterone and when do you use different things. It's really important to see somebody who completely understands that. I think as a transplanter, the max that I go to is, okay, maybe we can put you on an OCP and oral contraceptive pill. But there are a lot of other things that can be done that can help. But I would really encourage, there's lots of ways to get hormone replacement in Arizona, like testosterone's available in every corner, at least in Scottsdale. And that, you have to be cautious with who's giving it to you, the doses that you're getting, et cetera. So in summary, bone marrow transplant, it can be curative. I mean, it's something that, although you definitely need to have a healthy fear of, it is something that can be a curative option in the right patient. It's a really good thing to do. The best time for transplant is something that nobody really can give you. I can't say, okay, put your information in here and it's going to spit out when you need a transplant. There's a window. There's a window. Some people stay in that time frame that we'd want a transplant for a long time. And so it's trying to find that right time. And then making sure to understand the risk of your disease. So the risk of your disease is characterized by blood counts, is characterized by mutations, et cetera. These are really, really important to make sure that you completely understand. And then, again, it's a complex process. Really take your time digesting stuff. Make sure you see somebody sooner rather than later. There's so much out there. There's the BMT InfoNet. There's the NMDP or Be the Match. I don't know what they're calling themselves these days. There's a BMT RN coordinator who's going to be your lifeline and write down your questions. And when we talk about the donor choice and conditioning regimens and GVHD preventions, there's not one right answer. You really want to do what that center does because that's what they're good at. And thank you for your attention, and I will take any questions.